Hello, this video is going to be for chapter 17. It's going to be drugs for the endocrine system, largely diabetes mellitus. So let's get started. So basically, we're going to go through the difference between type 1 diabetes mellitus and type 2. There are differences. We're going to go and do injectable insulin and also oral antidiabetics. This is where we're talking about the pancreas. So the pancreas makes insulin. When there's a lack of insulin, that's when we can get diabetes mellitus. So basically, diabetes mellitus, basically what it means is the group of conditions that lead to hyperglycemia chronically. Either it be by a defect in insulin production or the action of insulin. That's kind of where type 1 and type 2 come in. So the main symptom of diabetes mellitus is going to be increased blood glucose levels. So glucose is what basically our main energy source for the body, so it's important that we have it in an appropriate range, because too much leads to problems. So there's there's also three types. It's type 1, type 2, and gestational diabetes. So uncontrolled diabetes can lead to a lot of problems. Hypertension, heart disease, stroke, diabetic retinopathy, basically blindness, kidney disease, diabetic neuropathy, amputations, periodontal diseases, pregnancy complications. All sorts of issues can lead from diabetes mellitus. But what is actually causing these issues? So what's happening is we have an increase in our blood glucose levels. Glucose is sugar. Sugar likes to coat things. Basically what happens is sugar levels get too high, it begins to calcify, crystallize on the body tissue and organs, basically glycosating things. So it causes basically glucose crystallizes on the tissue, on the organs, causing damage and then malfunction. So normal blood sugar should be between the range of 70 to 100. If it's below 70, you're hypoglycemic. If you're above 100, you are hyperglycemic. The other thing to be aware of is glucagon. Glucagon is the opposite of insulin. So insulin causes your body to basically store glucose in the tissues and the cells. And glucagon causes your body to release glucose from storage. So to help control diabetes, you get a combination of insulin, oral antidiabetics, and diet and exercise. That's primarily for type 2. Type 1 diabetes is only controlled through insulin. So basically, to be diagnosed with diabetes, you need to have the symptoms. So signs of polyuria, increased urination, polydipsia, increased hunger, unexplained weight loss, a plasma glucose greater than 200, or a fasting glucose greater than 126. The other thing that is important to know is a glycosated A1C, glycosated hemoglobin. When I was talking about the organ failure, I was talking about that glycosylation, which is the sugar that coats the organ tissues. Hemoglobin A1C is basically the percent of your hemoglobin cells that are covered in sugar. It should be less than 6.5. Anything greater than 6.5 is going to be criteria for diagnosis because it's too high. Because no matter what, some part of your hemoglobin is going to have some sugar kind of coated on it. When it gets too high, that's when the problems come in. Because if you have high glycosylation on your hemoglobin, it means you're going to have high glycosylation on your tissues and organs as well. So type 1 diabetes is insulin-dependent diabetes mellitus. That's the IDDM. So basically, what's happening is, for whatever reason, your pancreas got an autoimmune disorder that affects the beta cells. The beta cells is what makes your insulin. Your body's not making any insulin. So what we need to replace the hormone. Same with hypothyroidism. You have too little hormone, you have to replace it. Type 2 diabetes mellitus is non-insulin dependent diabetes mellitus, which we can either, it's going to be caused from insulin resistance. Either insulin levels are so high your body becomes used to it being in the body and kind of ignores it, or your pancreas can't keep up with the amount of insulin your body needs and kind of slows down. So this is generally going to be seen, type 1 is going to be more diagnosed in younger patients, and type 2 is going to be more diagnosed in, could be younger, or adult patients more commonly, because we also link to largely obesity. So for type 2, we can use insulin, we can use oral antidiabetics, or diet or exercise. Type 1, you have to have insulin replacement. You can't treat it any other way. So kind of with hypoglycemia, the old saying is, cold and clammy, have some candy, hot and dry, sugar's high. So hypoglycemia, cold and clammy skin. You're going to be a little diaphoretic, they're going to be sweaty, they're going to be a little anxious, they're going to have a headache, they're going to feel hungry, they're going to have decreased urination, tachycardia, blood sugar less than 70. Hyperglycemia, blood sugar greater than 100, they're going to be thirsty, they're going to have increased urination, they're going to have fatigue, dry mouth, fruity smelling breath, that's small breathing, weight loss, increased glucose in their urine. Eventually can lead to either coma and then death. So it's important to regulate these levels frequently. So how do we treat type 1 diabetes predominantly? We need to give them insulin, right? We need to give them synthetic insulin. The best way to give it is going to be through a sub-Q injection. We need to be sure we transfer the injection sites around to help prevent lipodystrophy. That's what it was. I was trying to figure out what that was called again. I'm sorry, it's been a long day. So basically it needs to be given as a sub-Q injection. Now we can give insulin IV. IV insulin is going to be largely for acute problems. We have extremely high blood sugar levels, you got to get down quickly. Okay. So slide 14 is a very important slide. There's a lot on this slide, but it's everything you need to know. You need to be aware of rapid, short, intermediate, long-acting insulins and also the combination. So you know the onset, the peak, and the duration. So first let's go over the names. So rapid-acting insulin, Lispro, Aspart, Humalog, or Novolog. Notice they end in log. Regular insulin is called Humulin R or Novolin. It ends in lin. And Humulin R is Humulin regular. NPH, or intermediate acting, is Humulin N. Humulin N, NPH, Humulin R, regular insulin. Your long acting is Lantus and Levemir. They have something unique. So, before we get into anything, we need to talk about mixing insulins. So if you're going to use a sterile insulin draw, you need to make sure you are alcohol wiping tops of both vials and keeping it sterile. Next, you're going to have your clear and your cloudy insulin. What is the difference between a clear and a cloudy insulin? Good question. So, rapid acting or short acting are considered clear insulins. Intermediate, NPH, is a cloudy insulin. So what we need to do is we need to make sure we are not contaminating our faster acting insulins with our long acting insulin. We don't want to contaminate our long acting insulin, our short acting insulin. We don't want to contaminate our short acting insulin with our long acting intermediate insulin. I apologize. So how do we make sure we don't contaminate our shorter acting insulins with our longer acting insulin? Well, we're going to draw up, after we sterilize the vials, we're going to draw up air and put the air in the cloudy insulin first. We're going to pull the needle out, redraw up air, and put it in our clear insulin vial. And then we're going to draw our clear insulin vial to the amount of doses we need. And then we go back to the cloudy insulin vial, drawing it up. So we put air in the cloudy, air in the clear, draw the clear, draw the cloudy. So by doing that, we're containing our faster acting insulins together, And so we're not going to get any sort of longer acting insulin mixed into the faster acting insulins. So it's important to note you can only mix your rapid and short with NPH. You can't mix long acting insulin. On your intermediate and your shorter acting, your rapid and your short. Long acting insulin, Levemir and Lantus, can't be mixed. They have to be given separately. Okay? Okay, so now let's talk about the different onset, peaks, and durations. What does the onset mean? The onset is the amount of time it takes for the insulin to have an effect. When the onset's coming, that means that it can begin to show signs of hypoglycemia. Insulin's having an effect. The peak is when the insulin's at its most potent, its highest effect. It's peaking, so that's when it has the highest risk of hypoglycemia. Duration is the amount of time the insulin is going to work on the body. So after duration is done, now what can happen is the insulin can start to come back up and get higher, so at risk for hyperglycemia again. So for the rapid acting insulins, let's combine all three in the one kind of easy to remember number. So let's remember our onset, 15 minutes. Our peak, 30 to 90 minutes. And our duration, 2 to 5. So we took an average of all of them. If you want to just look at it in one row, the Humalog Lispro low is kind of what we're going to use for our gold standard for the rapid acting insulins. Short acting insulin, regular insulin, onset 30 to 60 minutes, 2 to 4 hours for a peak, 5 to 7 hours for duration. Intermediate or cloudy insulin, 1 to 2 hours on an onset, 4 to 12 hours in a peak, and 16 to 24 hours. So this is kind of the intermediate range. It's lasting longer. Now our long-acting insulins, so they have an onset of 1 to 2 hours on average. We're going to average it out. Well, actually, say 2 to 4. It's fine. A very short onset. And then a peak, and no peak. So we can say they don't peak, because they just kind of this nice steady curve, and they stay flat, and they go off. Now the duration, let's say 24 hours. So remember, our long-acting insulin can't be mixed with any other type. So we also have a combination insulin, 70-30, which is a combination of Humulin R and Humulin N. And so with that, by combining both of them already in one vial, your cloudy and your clear, you now have 2 onsets, 2 peaks, and 2 durations. Notice how the peaks are a little different with the combination, the 70-30. The NPH goes from 4 to 12 to 6 to 12. So let's say we gave someone a combination insulin at, say, 9 in the morning. They had a late breakfast. And so now, what are we going to be worried for? We're going to be worried about 2 peaks. The peak of the regular and the peak of the NPH. So they're going to peak at around noon, 3 hours later. They're going to peak 9 hours later, which will be around 6 o'clock. So generally, hopefully, if we give it at 9, which is kind of an odd time to give insulin, but they're going to peak at noon and again at 6. So if they took it early in the morning at 7 o'clock and it's peaking around mid-afternoon, you want to give them a high-protein, complex carbohydrate snack. Usually the best thing to give is going to be like, say, graham crackers and peanut butter. So you want to kind of counteract those 2 peaks with the highest risk for the hypoglycemia. So basically the major risk factor for insulin therapy is hypoglycemia. You give too much insulin. You always want to check a blood sugar before, but if you're worried about how they're looking, do it at their peak. You never want to shake the body. You always want to roll it between your hands. You want to keep it in a nice, cool, dark place. It can be used for 28 days after it's been opened. You're also going to want to teach your patients to have a quick, easy source of glucose on hand in case they get low. Some sort of candy, orange juice, something like that, and then a complex carb and a protein for afterwards. You give the simple carbohydrate initially, get the blood sugar back up, then you give the complex carb and protein later after they stabilize to kind of keep the blood sugars up. So slide 16 basically is talking about how we draw it up. So we're drawing it up with the air in the NPH, air in the cloudy, draw the cloudy, draw the NPH. Because we're not going to contaminate any of the NPH into our quicker acting insulins. So a lot of facilities actually will do double checks for insulin before it's given to make sure that it's not causing any issues. The other thing is you also want to be aware of their potassium levels, because insulin causes electrolytes to go into the cell. So if they have a lower potassium, it's also going to be brought into the cell, which is going to lead to hypokalemia. So we're not worried about hypoglycemia and also hypokalemia. We want to monitor both. Next thing I want to talk about is a sliding scale. So a sliding scale works like this. They're going to have ordered, say, 5 units of insulin with every meal. Okay? And so with that, you now have a base dose. That's your 5 units of insulin. You're also going to have a sliding scale. The sliding scale is going to be based off of what their insulin numbers are. So say it's their noon finger steak for their lunch. Their blood sugar is 275. So based off that sliding scale we have on slide 19, 275 is between the 251 and 300. So it's calling for 8 units of insulin. So how much insulin should we give? We want to give them 13 units of insulin total. We take the base dose plus the sliding scale together, and that's their dose. So their base dose is based on how their diabetes is controlled. The sliding scale is the correction dose based on their current blood glucose. So they're going to eat a meal, blood sugar is going to go higher. They're already at 275. We give them additional insulin to help lower it down. Next, we're going to talk about oral antidiabetics. These are only going to be used for type 2 diabetes. These aren't going to be functional for type 1 diabetics. Type 1 is insulin-dependent diabetes mellitus. Type 2 is non-insulin dependent. So we can give patients who aren't type 1 but type 2 oral antidiabetics and kind of help control their blood sugar levels different ways. The first one is second generation sulfonylureas. So sulfonylureas are glipizide and glimepiride. So what do you need to know from these oral antidiabetics? Well, there's a lot of them if we remember the names. And kind of let's look at their side effects and what do they do and the administration rules. So sulfonylureas can lead to hypoglycemia. If it causes hypoglycemia, we need to give it with food. Okay? So any one of these that leads to hyperglycemia, give with food. Makes sense, right? It also leads to some photosensitivity and weight gain. Main one's going to be hypoglycemia. So if they can't eat, do you want to give something that's going to lead to hypoglycemia? I don't think we should. Next is the meglitidine analogs, pranidine, and then Starlix. So basically, these are going to be insulin stimulators. These are going to stimulate the release of insulin from the pancreas. So again, we need to have a functioning pancreas for this to work. If they're type 1, not going to work. So with this, we see hypoglycemia. With hypoglycemia, what do? We have to give with food. Okay, see how we're just going to I'm going to make this easy. I'm going to go over to the TZDs. These ones again have a few more complications. I skipped metformin, we're going to go back. So, these ones are going to lower blood glucose over a long term. So it's going to help maintain glycemic control over a long period of time. So it's not going to have a hypoglycemic effect. It's going to affect the ability of insulin it's going to decrease insulin resistance in the body. So it's going to overall increase the effect of insulin. So it's not going to have hypoglycemic effects. It doesn't take a quick effect. It's a more chronic control medication. So with this, you want to be aware of cardiac complications, fluid retention, and macular edema. But there still can be some potential for hypoglycemia, but it's hypoglycemia due to long term. So with this, we don't need to give it with food because it's not hypoglycemia after it. It's not going to happen like right after you take it. It's going to probably have a higher chance of hypoglycemia as things go on. So it doesn't have to be given with food, but those require a little more monitoring than the other ones. Second last one we're going to talk about is the alpha glycoside inhibitors. So this is going to decrease or slow carbohydrate absorption in the small intestine. So are we quickly affecting the blood sugar levels? Not so much. This one can actually be used for type 1 and type 2 because it's not affecting insulin at all. It's affecting the absorption of carbohydrates. So even though we need to give this with food, it's not going to cause hypoglycemia. We have to give it with food because it's affecting the absorption of the food. So it makes sense we give it with the food. Now let's talk about metformin. Metformin is the most common anti-diabetic for type 2 diabetes you're going to see. It does not cause hypoglycemia. That's why it's so used so often. It works very well. But there are complications. Lactic acid acidosis. Lactic acid, what is it? That's the acid that's made after anaerobic metabolism. So when your body runs out of oxygen, you go through the Krebs cycle, make lactic acid, make your energy. So lactic acid is, sorry about that, I had my phone on the table and it was vibrating. So metformin, so it has an increased risk of lactic acidosis, which is not good. Too much lactic acid can lead to kidney and organ failure, so you want to monitor it. So if you have muscle pain and then decreased kidney function, you want to be aware of it. You also want to be aware of kidney function. Metformin can lead to nephrotoxicity. So, there's always going to be an NCLEX question about metformin and contrast dye. Contrast dye is going to tax your kidneys. It's going to tax your kidneys and lead to kidney failure. So if you have two things that are going to tax your kidneys, metformin and contrast dye, you're going to go into acute kidney failure. So you want to avoid it 24 hours before they go for any sort of CT or MRI with contrast dye. So slide 25 basically has complications of uncontrolled diabetes, which we've already kind of covered. So diabetic retinopathy, diabetic neuropathy, diabetic nephropathy, stroke, heart disease, foot damage, hearing impairment. So it's all basically complications related to the glycosylation of your body tissues. So we're always talking what we're going to do for hyperglycemia. Let's talk about what we're going to do for hypoglycemia. Well, what did we say before was the opposite hormone to insulin? Glucagon. So if blood sugar is too low and they got to the point where they're not able to take anything by mouth, they're unresponsive, we can give them an IM injection of glucagon. Glucagon is going to stimulate the organ that breaks down glycogen. Glycogen is your stored glucose. What organ breaks down glycogen? It's your liver. So it's going to cause your liver to secrete more glucose by breaking down the glucagon. Okay? So basically with this, you go from hypoglycemia to potentially hyperglycemia. So something to be aware of. Once you give this, you want to make sure you're monitoring the blood sugar levels after you give it. So a few things to be aware of. Let's talk about diabetic ketoacidosis a little bit. Basically in diabetic ketoacidosis, what happens? Basically, there's uncontrolled blood sugar levels. Your body has no insulin. It's not taking in any sort of glucose. Your body's not using glucose for energy anymore because there's too much of it. Insulin's not doing anything. Body still needs to make energy. So what does it do? It's going to break down fats and proteins into ketones, and ketones are acidic. So what do you get? You get diabetic ketone acidosis. Acidotic ketones in your blood. You're also going to see elevated potassium levels, elevated BUN creatinine, because kidney function is going to be going down. They're going to have extreme hyperglycemia, acidosis, electrolyte imbalance, thirst, fruity smelling breath, and increased urination, because your body's going to try to secrete all the extra glucose through the urine. So what do we want to do? We want to get the body back in homeostasis. You're probably thinking they're extremely hyperglycemic, let's give them insulin first. And that's actually wrong. Because even though the insulin the blood glucose is high, they have other problems going on as well. They also have acidic blood. They have elevated electrolyte levels. So how do we dilute this? We give them fluid. You want to give them a fluid bolus before you give them anything else. Give them fluid, rehydrate them. They've had increased urination for a while. They're dehydrated. They're acidotic. We gotta give them fluid and dilute their body out. And then, after we give them a lot of fluid, then we give them insulin through an IV injection. And that's pretty much it for Chapter 17.